Hello everyone, my name is Nelson Min and I'm a specialty course faculty for Aspire, and today I want to show you a technique to treat the maltracking hip using dry needling. The hip joint is capable of producing a spin, allowing the hip to stay in the sagittal plane in flexion. Occasionally, the soft tissue structures of the hip disallow this, creating an abduction moment in flexion. Left untreated, this can progress to increased pain, disability, and further impairments. One of the soft tissue structures that can contribute to this maltracking hip is the piriformis. It is attached to the anterior aspect of the sacrum from S2 to S4, traveling down to the medial aspect of the greater trochanter. When this muscle becomes facilitated, it can create an abduction moment at the hip, leading to general hip pain. What we're going to do is identify the piriformis by first finding the greater trochanter. Take the palm of your hand and place it right over the lateral aspect of the greater trochanter, and allow your fingers to fall over the soft tissue as it travels towards its proximal attachment. Furthermore, compress and palpate into the tissue until you feel the bony backdrop of the posterior acetabulum and posterior femur. Compress, spread the tissue to create a window of treatment. Place the needle between your fingers in an oblique direction. Quickly tap. Slowly advance the needle. Slow enough to allow your patient to verbalize any adverse response that you can adjust. Advance the needle until you get to the bony backdrop of the posterior femoral hip joint. Hold on to the needle and let the tissue recoil. What we have here is the PSIS, iliac crest, L5, the lateral border of the sacrum, the ischial tuberosity, and the femur and greater trochanter. This green arc here is the pathway of the sciatic nerve. To protect my patient's modesty, I'm going to continue this technique demonstration using this pelvic model. We put a needle into this area indicated by a 1, which goes through the glute max down to the piriformis onto the posterior aspect of the acetabulum. I'm going to put a second needle indicated by a 2 that goes through the glute max down to the quadratus femoris on this side, on the distal side of the hip joint. All three, number 1, number 2, and the posterior hip capsule, all share a common innervation, in part, by S1 ventral rami. This will decrease the resting tone of all three, thereby improving the hip's ability to produce flexion in a pure spin. After your technique is finished, you should recheck your patient's hip flexion, that it is improved and tracks better remaining in the sagittal plane. It is most important to reinforce this with strengthening and stability exercises. If this was interesting and you'd care to know more about Aspire courses, look at our website at ASPIREOMT.com. Thank you.